Welcome everyone to the fourth lecture of CPH 290. So today it's a great pleasure to have Professor Julia Adler-Milstein. Julia is a professor of medicine and chief of the Division of Clinical Informatics and Digital Transformation at UCSF. She conducts empirical research that guides the US healthcare system towards effective health information technology adoption and use. Her specific expertise is in policy and organizational strategies related to the use of IT in healthcare delivery. And her research assesses the progress of health IT adoption, the impact of such adoption on healthcare costs and quality, and the relationships between market, organization, and team structure and health IT use. And today she'll be talking about her work, which includes studying the adoption and use of emerging AI tools and approaches to health system governance. So thank you so much, Julia, for joining us today. I'm going to hand it over to you.
Great. Well, thank you so much for inviting me, and I'm really thrilled to be presenting to this audience today. I am in sort of an interesting career transition where I'm moving from sort of just doing my own research as a PI to now having been given the opportunity to create a new division at UCSF, which is in, I guess, our lingo, it's sort of one part of a department. And within the Department of Medicine at UCSF, we are sort of the first non-clinical, well, that's actually not true. We are one of the first non-clinical divisions. We also have a division of prevention sciences that also, and so likely many folks on the session today may know that there's departments of biomedical informatics that exist at many other institutions, and I'll say at UCSF, and now that we have sort of UCSF and UC Berkeley programs, like we do it a little differently here. We've sort of divided up and organized the world slightly differently. We don't have one department of biomedical informatics that sort of houses the equivalent of what you might find as CPH in other places, or my division, the Division of Clinical Informatics and Digital Transformation. And then we also have the Baker Computational Health Sciences Institute. So I think at many other places, you would find those three things under one department's umbrella. But here we sort of have these different, we've done a little bit more of, I'd say, a ground up approach of organizing these different things. One's a program, one's a division, one's an institute. So if it feels a little bit confusing, like I think you're not alone in feeling that. But I don't know that there's like a better or a worse structure, especially because I think we all work really well together. And as one indicator of that, it's being given the opportunity today to come and tell you about the division, and hopefully that will give you a sense of what we're doing and how it might fit into your work and interests. And I'll just say that one of my goals is that anyone who's associated with CPH feels that they have a home in this division. And that could be in an informal way where you just come to our events, or that could be in a more formal way, if you want to work with our faculty, or so anyway, there's lots of opportunity. So this is just the first of what I hope is a relationship where you understand what's happening in the division and you come and join us in whatever way is most useful. So I'm going to mostly spend my time today talking about the division, and we'll touch a little bit on my own research too. But I'd say at this point in time, I felt like it was most important to talk about the division, though if you're, again, interested in my own research, always happy to talk about that too. So to this sort of point of like mapping the domains that sit within biomedical informatics, I think this is like a helpful schematic because it shows these different axes from sort of more basic, not more basic, just basic, what we would call basic research, to applied research and practice. And then from sort of molecules, cells, tissues, and organs, all the way up to sort of patients, individuals, population, society. And so where I think most of the work that we're doing in the division fits is in this box off to the right, where we're doing very applied research as well as practice. We're working with our health system to figure out how they should deploy and monitor different types of tools that are being used by UCSF health clinicians. And most of the research we do is really about sort of how technology changes like patient care outcomes, some more public health informatics use cases. So that I think is really where you'll find the center of activity within the division. But obviously, again, if you think about what's happening at CPH or the Baker Computational Health Sciences Institute, that's where, I'd say the more biomedical informatics education and research is happening. So, very, very adjacent, but perhaps helpful just to think of those as somewhat distinct. So the mission and vision for our division, the mission is, that we really want to be the home for clinical informatics research, training, as well as guiding health system implementation of technology in ways that improve care. And I think the vision statement is perhaps even a better distillation of our goal, which is to be an international academic leader and how to bring technology and people together to optimize healthcare. And so again, what you are less likely to find in the division and what you're probably more likely to find at CPH is someone who's trying to develop a new model that helps understand like the best treatment or best approach to diagnosis, for example. And what you'll find in our division is people who are thinking about like, well, how do we design technologies that are going to best fit into clinical workflow, for example, or how do we understand how AI scribes are changing the amount of time that clinicians spend on documentation, or how that changes team communication? So those are kinds of questions that I think really think about this combination of technology and people to optimize how healthcare is delivered. The leadership team in the division is myself as chief, and then we have associate chiefs that really span the 3 mission areas that you just heard about. So AJ Holmgren's our associate chief for research. So if you have questions about research opportunities in the division, he would be your point person. Raman Khanna is our associate chief for education, and he is the director of our clinical informatics fellowship, which is the one training program that sits in the division. As you may, I suspect, have heard of clinical fellowships, right? People who do a fellowship in cardiology or in, surgery. We also have a clinical informatics fellowship that's accredited. And so those are all physicians, and they come and spend 2 years with us and really learn the science of clinical informatics. So we have 9 current fellows. And so that's, again, another opportunity to come and interact with a set of trainees who are specifically being trained in the field of clinical informatics. Sarah Murray is our Associate Chief for Health System Partnership, and she also is the Chief Health AI Officer. So she's really the point person for thinking about how the division can best integrate with what's happening at UCSF Health, and with a specific focus on where the division can help with the development and implementation and monitoring of AI tools. I'll talk about that more in a moment. And then we have a division manager who's just sort of like the master of everything. If you have any questions about the division, she knows the answer. And then Robert Tombley, who is our director of data and analytics. A lot of people come to us with questions about how to use different aspects of UCSF Health, usually Epic or EHR data. And he's really the guru of that. And in particular, a subset of Epic EHR data that we have, I'd say, built national expertise in, which is metadata. So all, not just the clinical data, but sort of all the metadata that sits around it. So just to be specific about what that is, like imagine a clinical note that gets created, right? There's like the content of the note itself, but then there's also all the data that gets created around like who started the note, how much time did they spend writing the note, how much did they then come back to edit it? Did someone else view that note? Did that note get appended later on? So it's a huge amount of metadata that really sits around the production of clinical documentation. And there's a whole interesting set of research questions that I'm personally very excited about by using those data that really help us study the like viewing and creation of information, which is at the heart really of clinical decision making and outcomes. So he is, I think, probably the nation's expert in those data and how to use them. So we're just a little bit over a year old as a division. We started in the summer of 2023. And so in our first year, we've actually grown like tremendously. We have 12 faculty with primary appointments, and we have 3 new faculty who are starting over the course of the next year, who we hired last year. And they're all PhD faculty, and they are I'd say all quite computational. And so I think, again, will be opportunities for those faculty to integrate with CPH as well. So I'm really excited about growth in primary faculty. And then we have 40 faculty with secondary appointments. These tend to be clinician researchers who are in, another clinical area, but do informatics research. So they have a primary appointment in their clinical group and then a secondary appointment in doc IT. And then we have our clinical informatics fellows and then staff who largely support our research enterprise. So these are our primary faculty. Again, maybe may have some familiar names on them. And then we have our 3 faculty joining next year. And then I think at that point, we'll sort of be about half PhDs and half MDs, which again, for a division of clinical informatics, I think feels about right. These are our clinical informatics fellows. Again, they are all actively working on different projects, some more research focused and some very health system embedded. But they are great resources because they also have like broad access to UCSF Health EHR data, and they tend to know our sort of environment and like data analysis tools very well. And so anyway, they are also a great resource for working in the UCSF health environment. So for our secondary appointments, these are the 40 faculty I mentioned. 26 of them are in some other part of the Department of Medicine. So cardiology, gastroenterology, general internal medicine, et cetera. We are also, as you may or may not know, UCSF has these sort of, we think of it as like three organizations that in some ways are independent, but in some ways are together in the sense that the faculty are cohesive. So it's UCSF, the Zuckerberg San Francisco General, and the SFVA, the Veterans Administration. And so 39% of our faculty come from sort of not UCSF, so from either ZSFG or SFVA. So again, if you're interested in like working on a project with VA data through the division, we can help get you connected to the faculty who are based there. And then we have 14 other faculty who are with secondary appointments in other departments and schools. So again, we have people coming even from nursing, epi-biostat, et cetera. So we really are a very cross-cutting division. And so as you're thinking about, where there might be opportunities to especially meet collaborators, the division is a nice place to come and get connected. Okay, so I'm going to just tell you a bit more about the structure of the division. It's going to get a little acronym heavy, and so if I've lost you in the acronym soup, just stop me. And I'm also happy to send out these slides so you can come back and refer to them. So we have our leadership team, who I told you about a few minutes ago. And then we have these cores that sit within the division. So we have a research services core, again, that support extramural research projects. So those are our, research assistants, program managers, project managers, et cetera. The data and analytics core, I told you about Robert and some of the specific expertise we have there, but also other analysts. And again, for people with funded projects, we're able to come and be able to dedicate our staff to support your project if that's something you need. And then in our core services, we have like our director of communications. We put out a monthly newsletter. If you would like to receive it or not, let me know. And it's just a nice digest of sort of all the things that are happening within the division. So that's our sort of core services team, is like communications, administration, et cetera. And then we have what we call our verticals, which are, I'd say, like programs and initiatives that are like bigger than just one person. So our clinical informatics fellowship I told you about. The Center for Clinical Informatics and Improvement Research is one of 2 research centers that sit within the division, and really thinking about using that EHR metadata for different types of research projects. That's the sort of hub of activity for that expertise. And so there's like a monthly webinar that they run. They do a lot of other activities, again, for people who are interested in that kind of research. And then our newest research center is called ADAPT. It's the Center to Advance Digital Physician Practice Transformation. That's led by Lisa Rotenstein. And that's a lot of multi-center studies of sort of new technologies that are changing some aspect of physician practice and trying to understand how that's changing sort of the physician work experience as well as practice patterns. So welcome to reach out to Lisa. That's, I'd say, just starting to launch. So there'll probably be more things that you see coming out of ADAPT soon. Codex is our National Coordinating Center for Diagnostic Excellence. That's a very externally facing coordinating center that's really meant to kind of bring together people who are interested in achieving diagnostic excellence and ensuring that there are opportunities for them to share and coordinate their work. So this past weekend, we had a national meeting in Minneapolis that had lots of incredible research presentations for people who are working on different aspects of this. And I'd say a huge focus within that is really on AI and how AI is changing the diagnostic process. They do a monthly virtual webinar that's, I think, called like at the crossroads of AI and diagnosis. We've had a really interesting set of speakers there, again, totally open for anyone who wants to attend that. And then last but not least, and I'll talk about this more in the second half of my talk, is our partnership with UCSF Health. And we were fortunate that we were starting the division at a time when UCSF Health had a new CEO, Suresh Gunasekaran, who was very interested in partnering with the division and trying to see where our sort of skill set could help UCSF Health, be savvier with their approach to technology. This is not like running the EHR day to day, right? Like that sits in the health system, like they do that work. But this is really around sort of more innovative tools where we need to be able to study them and understand how they're changing clinical work and are they delivering the value that we expect. So we have a set of I'd say, research collaborations with the health system, the biggest of which is called IMPACT. And this is a partnership where we'll really be developing the approach used at UCSF Health to do monitoring of AI tools on an ongoing basis. So once an AI tool is sort of validated and implemented, doing the ongoing monitoring around that. Anyway, I'll talk more about that as I move on in my talk, but I'm really excited about the opportunity to partner with the health system and try to both deliver a product that they need, as well as create space to do the science, because there's tons of important scientific questions around how to do AI monitoring. And so I really am hoping that we can kind of create that type partnership. And then, of course, we have like all the research that our primary and secondary faculty are doing, and lots of opportunities with just within their individual, labs and research areas. So let's see, I think there are a couple questions. So let me pause here. So I'm a Haas MBA student working in this space. Can you approach the division for help? Yeah, so I think the short answer is like you absolutely come to the division. When you say help, I think that it will depend on what kind of help you need. We try to be like open to anyone for like relatively straightforward consultations. If you're like, I'm just trying to understand how to go about this. If you're like, could you build me a brand new complicated data set for my student project? I wish we could do that, but that's where we just unfortunately don't have. We have not been resourced to do that kind of work, and so we'll be very clear with you about sort of what we can and can't help with. But yes, the short answer is you can reach out to me, or you can reach out to one of those leaders who I just showed you if you know where your interests align. So do I mind explaining the optimized healthcare I mentioned earlier? Yeah, I think I'm going to talk about that more in the second part of my talk. So if I don't get to that, then come back and ask me that question again. But that part's still coming up. In some ways, I'm just doing the boring, like who's the division and how are we organized part now, and then we'll get to the more fun stuff about the optimized healthcare. And there's a question about exploring the use of multi-agent LLM-based conversation to collect patient-reported outcomes. Okay. Yeah, so if you're sort of trying to figure out how to navigate UCSF Health, and you're like, this is my interest, how do I find where in UCSF Health I might be able to kind of find a collaborator who's interested in this, then yes, definitely. We are always happy to help with sort of wayfinding triage, like who might I talk to pursue a project idea. So definitely reach out about that. Okay, so I will keep going here. So again, just in terms of the, again, you can always come to me, but other people that you might want to go to, these are the leaders of each of the different verticals that I just described. So you can reach out to these folks as well. Okay, and then I think this is my last slide about the division. We're trying to just make widely available, seminars, events, meetings. So some of these are happening at the national level. So we held a really interesting meeting a couple weeks ago on strategies to protect sensitive health data. Unfortunately, we're seeing patients who are having to travel from other states to get reproductive and other types of sensitive healthcare here. And so we're thinking about the informatics strategies that are needed to be able to protect that information while still ensuring, continuity of care and information sharing that we also know is really important to delivering high quality healthcare. So we had a really interesting meeting about that. The Diagnostic Excellence Conference I mentioned last weekend in Minneapolis. We have the AMIA conference coming up in San Francisco in November. And so we'll be doing some programming around that, hopefully in collaboration with CPH. Again, I mentioned the innovations at the intersection of AI and diagnosis. That's a virtual seminar series that anyone is welcome to attend. We also have a monthly National Research Network for EHR audit log data or metadata. That's another monthly seminar series that's welcome to anyone who's interested in those data and how they're being used. So again, if you go to our website, you'll be able to find all of these different opportunities and sign up for anything that's interesting. And then just within our UCSF and DocIT community, we do a monthly health informatics grand rounds. We have a seminar series on evaluation of AI in real world clinical settings. I know CPH has also been a real partner on that one. So hopefully that's something that's on your radar already. And then we do, research brown bags, work in progress seminars, and our division meetings, which again, people are welcome to come to. So again, the goal is to just, I hope convey that there's lots of opportunities to get involved with the division and in ways that hopefully fit the things that you are specifically interested in. Okay, so I think this was in some ways the question that came up earlier, which is we are the Division of Clinical Informatics and Digital Transformation. And I have talked a lot about clinical informatics. I have not talked as much about digital transformation, which I think of as, the ability to use research to really understand how to optimize how healthcare is delivered, given the set of digital tools that we have available at this point in time, which is like an incredible set of digital tools, but not ones that we always know how best to integrate into healthcare delivery, like which ones are really ready for frontline clinical use and which ones are not, and how do we develop those tools to be ready. And so digital transformation is kind of a buzzword. I'm not sure anyone really knows what it means. I did like a Google Images search for digital transformation, and this is just one of the kind of images that come up, right? It's like not clear what it actually means. It just seems like it's like, has to do with like data and people. And so, one of my challenges as division chief is like to put substance behind this part of what we're supposed to do in the division. So where I think we are really working on digital transformation is around AI and how to get AI safely and effectively integrated into our health system. And so right now, that's really been the focus of division efforts around digital transformation. And so what I want to do is just to tell you a bit about this. Let me just pause and make sure that has this group had a talk already on sort of UCSF Health AI governance? Because if you have, I don't want to. No, okay.
This is the first one
that
gives that kind of perspective.
Okay. Perfect. So I'm going to cover this. This has really been work that's been led by our Chief Health AI Officer, but again, with support from the division. And so I think this is a helpful way to kind of set up and explain where there's going to be opportunity to do this work. So the opportunity for AI governance is really, there are two parts to it when you boil it down. One is like the priorities of the organizations. What problems are we trying to solve? And where do we think AI is going to be valuable in solving those problems? And I just will say, like, the health system's goal is not to use AI. Like that is not, their priority. Their priority is to run a health system and to figure out where AI can help them most effectively run a health system. And so that sort of matching of problems to tools is like where our Health AI Steering Committee is really charged with that work. And I'm going to show you their roadmap in a minute because I think it's really helpful to understand like where they see opportunities for AI to be valuable. Which doesn't mean that if you're interested in a different application of AI, that there won't be room to partner and to be able to do some of that research work within the health system. But it may mean that at the point you do your research study, if you then say, well, health system, do you want to pay for this tool to exist as part of your, IT infrastructure that you manage? They may say no, because it's not part of their sort of set of priorities. But again, I want to be clear that I think the health system is really committed to sort of supporting individual researchers and the experimentation with AI tools, even when it doesn't always perfectly align with their top line strategic priorities. So that's health AI steering, which is, again, what types of AI solutions should be prioritized and resourced that address health system needs. And then health AI oversight is the complement to health AI steering that helps to ensure that whatever AI we've decided we want to implement, that it's trustworthy. And again, I think a lot of folks are working in this space because it's very complex to figure out, like, does this tool, is it safe and effective and ethical and all the other dimensions of trustworthiness. And so I'm going to talk more about the health AI oversight process. And again, the goal is to be able to do this quickly and nimbly, which is hard because the tools are moving quickly. There's a lot of different opportunities. And so how do we design a governance structure that's both rigorous, but also nimble? So this is, again, UCSF Health's 2024 roadmap for health AI. So this is where they are making investments in tools that they think will address important health system priorities. And what you can see is that a lot of this is, I will say, more administrative, but I actually think it's deeply integrated into clinical work. So it doesn't mean that it's not being used by clinicians. It just means that, like, you don't see improving diagnosis on here. But you do see things like improving provider experience. How do we help them spend less time on documentation and chart review? How do we improve revenue? Again, if you think about what's important to a health system, not surprising that thinking about how we can use AI to do things like reducing claims denials, improving our case management index, reducing days and accounts receivable, right? These are functions where there are AI tools out there, and that can be very valuable to a health system. Streamlining patient experience, right? So things like operational efficiency. We have a huge new contact center that we're putting in so that patients can have a streamlined approach to reaching out and making appointments at UCSF Health. And so again, trying to think about where is there opportunity for AI to help get the patient to the right clinician for their situation. And then again, are there tools that we can use that will just help ensure trustworthiness and reduce risk? Because right now it's a very manual process of doing that review. And so we're trying to understand, are there opportunities for AI to actually help us review other forms of AI for trustworthiness? So there's some interesting work going on there. And then again, you can see some of the very specific initiatives that we're working on right now. So AI scribes, large scale rollout happening right now. Partly what we are trying to do as a division is to get the data about that out into the hands of researchers, because many people want to study different aspects of AI scribes. And so we are trying to build a data mart that will allow people who are interested in doing research around AI scribes to do that in more of a self-service way. And then there are a lot of tools that Epic, our EHR vendor, puts out. And so we just, Sarah Murray's team just finished a large assessment of all the Epic tools and have basically prioritized which ones they're going to roll out. And then again, you can see sort of this broader set. I talked about the contact center and our AI program development. So really important slide. Again, happy, I think, to share it because it gives you a sense of where the health system's priorities are as they're thinking about making AI investments. So I'm not going to say too much more about kind of the strategic part of health IT steering, but just to say that they have a process for, like, engaging all the business owners of these different areas. And so that, again, it's really aligned with, like, the health system priorities. And that for this group is, I think, helpful to know, but, like, most of us, like, we don't work in the health system. And so that's perhaps a little bit less important to know all of the details about how they are developing and prioritizing different problems and therefore opportunities for AI. Let me just see, it seems like one more question came in. Master student at UCSF working on a startup project to help doctors save time on EHR with AI agents, particular projects, and collaborating with doctors in cardiology. Yeah, so I mean, I would say, again, our chief health AI officer is probably the right person to start with. and she can navigate you to the right groups. Again, I'd say like AI scribes are, it's just important to know that that is like the main thing that we are deploying right now. And so I think, being able to describe how AI agents work, hopefully in a compatible way with AI scribes would also be helpful going in, so that it's clear how what you're working on is complementary. Okay, so I will keep, or Adam, Ahmed, any questions in the room?
Any questions? Yeah, I think one question I had is like,
No.
I feel that there are like two different types of AI, like the more administrative stuff, which it seems to be what this roadmap is focusing on. But like, how do you view the other like diagnostic, like imaging based, like radiology? Do these types of AI also fall under the DocIT umbrella, or like is this like a different scope of AI deployment?
Yeah, I mean, I would say that in general, those sit within the departments. So like Department of Radiology is the one that's really thinking about like radiology AI applications. And that's not what I'm presenting to you is sort of what's happening at the enterprise level. And I'd say as a division, we're really engaged at the enterprise level, but that does not mean there are not individual researchers who are interested in applications that fit in sort of different specific clinical areas. And so, we're not going to probably build like, I mean, Department of Radiology has a lot there already. So I don't want to duplicate that. And so if you're interested in like anything that's happening in the imaging space, like I would go to radiology. That's, Sharmila, John Mongan, Mark Coley. So there's sort of a set of faculty who are really the leaders in like, AI and imaging. And
Yeah.
same with other areas, but I think you are right that like diagnosis as an enterprise priority for AI does not exist. So there's not someone who's just like, how can we use AI to improve diagnosis across the board? So you would then need to go to a specific clinical area and really figure out sort of like, is there a person in this area who's working in their division or department on that opportunity?
Yeah, and just one other question to link with the previous talk that we had on the regulatory landscape of AI, and I wonder if the AI scribing systems go through any regulatory process, or do they like where does this fit in the ECSF deployment cycle? Do things just get deployed?
So we have, I'd say, and I'll show you this in a minute. That's like literally where I'm going next, is around our governance process for oversight. But no,
Yeah.
I mean, unless like the FDA framework, unless it's operating like a medical device, which an AI scribe is not considered a medical device, it does not go through FDA approval. So it's, I don't know. Some people think that's a good thing. Some people think that's a bad thing. But the short answer is like right now, there's not that level of regulatory oversight. There is discussion about how we could do some of this validation at scale so that every health system doesn't have to do it themselves. And so that's, there are some industry collaborative groups that are forming to try to solve that problem. Okay, so let me get into the health AI oversight piece. Again, the goal of this effort is to ensure the trustworthiness of any AI tool that we deploy at the enterprise level, and how to think about, again, the longitudinal monitoring of that tool after we do the initial evaluation. Also ensure that we're in compliance with existing laws and regulations. There are actually some state laws that are coming, as well as some federal updates to that OCR has put out, where we will have to do some assurance that our governance and oversight process is like meeting these state and federal requirements, and to be a forum for identification of best practices related to AI implementation and evaluation. And again, this is a space where we need researchers and clinicians, and we have our regulatory compliance people. So there's a lot of need for coordination here. Again, for this level of enterprise oversight, we're really talking about any AI tool that's piloted or deployed within UCSF Health. That could be something that we develop ourselves, or that's developed by a vendor, or that's developed by a researcher. And again, but it needs to be used sort of, the vision is at scale in patient care operations. And so That's the scope of this piece of oversight. We have built our approach around HHS's domains of trustworthy AI, which means that when we evaluate a tool, we have measures of each of these. So we need to ensure that it's fair and impartial, transparent, explainable, responsible, accountable, et cetera. So any tool that a researcher wants to bring through the oversight process should be prepared to be able to show the committee that they've assessed whether the tool is performing acceptably in each of these domains. Again, understanding that no tool is perfect and there will be trade-offs, but we just need to know that there's at least been thought given to these different areas, and that you can bring a transparent set of performance measures to the committee, so that we can think through whether we feel like that is a reasonable performance profile of trustworthiness to be able to put the tool forward. So Amit, I think this was your question about like the actual oversight process itself. And again, this is it can look a little different in different circumstances, but generally there's an initial consultation that's done with the team that sits within the Chief Health AI Officer, and there's like an intake form. And so again, if you have developed a tool and you want to deploy it at UCSF Health, you would just fill out this form, and then there may be some back and forth to just make sure that we think like all the information is needed. And then there's usually a retrospective evaluation that happens of the tool. And again, sometimes people are coming with that at the start, so you're already ready. You've done the discovery, you've done the development and evaluation. So the first time it comes to this oversight committee is once the retrospective evaluation is done. And then we look at the outcomes, basically, of the retrospective evaluation that, again, covers those trustworthiness dimensions that I just mentioned. And then we make a no go decision about whether it's ready to move into prospective evaluation. And the reason that that's an important milestone is that to do the integration work for the prospective trial right now is like still takes resources. And so we do need to think about that transition, but there's, I'd say, a future state in which it would be amazing to just have that not be so costly, so we could move more tools quickly into prospective validation without having to, sort of stop projects before. So again, I think we're trying to see whatever we can do to take out the need for that A step. And then again, the committee reviews the results of the prospective evaluation and then decides if we're ready to move into sort of a pilot RCT, which is a much more sort of robust development on the integration and training and the design of the pilot itself. We look at the results of that, and then we really decide, is this ready for sort of enterprise scale and ongoing monitoring? So hopefully this is helpful in thinking about the process. I think it looks more, I mean, it's all the pieces are really important, but like we can move tools quickly through it when they're really ready. And so, it's the goal is not to sort of slow you down and sort of have so much bureaucracy that you can never get anything done. Really, the committee and the whole team, I think, really wants to get AI tools in place, but we just have to be sure that we're putting things in place that have been thoroughly thought through and that are safe and effective and trustworthy. So again, just to give you a sense of like what's been put through this pipeline so far, you can see it's a mix of tools that have come from our EHR vendor, again, that are aligned with that roadmap I showed you, some that have been developed by researchers and some that are being offered by third-party developers. Again, the AI scribing tools you can see are from Abridge and Ambience as our two vendors right now. So I think this gives us a sense that the process is working, and we've had enough that have come through that we're really learning how to do it, I think, as efficiently as possible. Okay, let me see. Yeah, any questions on that piece? Because then I'm going to go on to the monitoring and do a bit of a deeper dive there for the rest of our time.
There's one question in the room.
Yeah.
One of them is if we share the tools that are very equitable. Can you talk a bit more about how you use that?
Yeah, could you hear the question, or should I? Okay, so she was asking about the process of ensuring that deployed tools are fair and equitable, and whether how is that evaluated?
Yeah, absolutely. I mean, it's one of on sort of what I keep calling it an intake form, but it's like for every project we have sort of like a working document that has all the dimensions of trustworthiness, and so in that domain, like we ask for performance against sort of key patient demographic groups. Again, for some tools, like there are certain demographics that we're perhaps more or less worried about. And so we haven't said like, you only have to show us these 3 demographics and that's all we care about. And we haven't set like strict performance. Like if you see more than 10%, variation for race, then we're not going to consider it. Like there's just not a lot of hard and fast rules right now for sort of, so that's why you need a committee. And again, to bring the set of experts together to look at the performance and sort of decide if we think it's acceptable or not. Again, a lot of it comes down to like, well, what is current state, right? Like, is current state equitable, or do we know that current state is inequitable? And even if some differences persist, as long as we're doing better, then maybe that's okay. So it's really tricky. Like this is, I think, actually where, where the hardest decisions have to be made in this process is like looking at the results and figuring out if we think that that we've done it. But I'd say right now it's maybe not, it's not super structured so that every tool is going through like the exact same you have to think about that dimension, but it's not being done in a way where we're saying you look at these 3 variables, and if you see performance above or below this, it's a like yes, no. It's much more sort of show us what the performance is, why you think those are the right variables to assess for your tool, and whether we think those differences are acceptable or not. And I'll just say in some of the tools we've looked at, like they don't even always go in the directions we predict, and we don't know why. Like we just reviewed a tool where I think the performance was like better for Black patients than compared to all other groups, and we don't exactly know why that is. And so what do you do? do you say, right? And we still think everyone was better off than current state, but you could see that like our Black patients would disproportionately perhaps benefit from this tool. Like that, there's no, there's nothing that will tell us what the right decision is there. It's a really tricky and interesting space. So I'm not sure that's the most satisfying answer, but it's just the reality of where we are right now, I think, within these early stages. Okay. I see a couple of questions in the chat. So when you say there's a question about the community advisory board. So we have like many patient and family advisory councils. I don't know if that's what the question is about. We have not, at the enterprise level, there is not like a patient family advisory council specific for AI. And so, again, I think that's an opportunity for thinking about how to best design patient engagement. When I talk about the AI monitoring, that is where we are doing some patient and family engagement to get their preferences around AI and AI transparency. So I think that we are very much trying to engage patients and families. But if that's not the question you were asking about, then if you can maybe clarify it by asking a new question, I can address it more directly. Have the UCSF developed tools been tested and published in peer review? So some yes and some no, and some the goal of putting them in is to be able to test and publish them. So it's not a requirement of our process that you publish. The researchers, that is usually their goal. I'd say from a division perspective, for tools that we are involved with assessing, we usually want to publish on that. And so again, the goal is, I think, both to address the needs of our health system, but also to do the science and publish on the scientific questions that are being answered as part of that. So yes, you could like go look at some of these and find, research studies tied to these specific tools, and at other institutions too. And then to what extent do decisions made by the EHR vendor constrain options? Yep. So yes, if we think that Epic's tool is good, there is a strong preference for using that tool because it already comes sort of pre-integrated, so to speak. And so it's a lot less costly and complex to implement and maintain. So that's why we do usually give preference to an Epic developed tool. And at least we really want to understand what they are offering us, but it's not blind. Like we don't just say, oh, Epic's developed this, let's turn it on tomorrow. Like it goes through the same oversight process so that we're confident that the Epic tool is as good as any other tool that we would implement. So the governance process is the same, but if you're sort of saying like, a researcher brought us a tool and Epic brought us a tool, you know, those are hard situations. We don't see them that often, but it is hard because in the long run, the Epic tool will be easier and less costly to maintain. So we have to kind of make decisions about how to approach that. So yeah, so I'd say not absolute, but definitely there's, I'd say, you know, a tie goes to Epic probably in most cases. Okay, last week's seminar was a brief discussion of in EHR tools versus out of EHR tools. They prevent regular integration of out of EHR tools. Yeah, I mean, it's a great question. And I think, again, the goal is, per the prior question too, is like we want to have as open and innovative an ecosystem as possible so that we can just use the best tools and not have to think about who they came from and like how they're configured and, you know, are they using, you know, like a Fire API to, you know, read or write data. But the reality is like there's just still friction involved in the tools, and so we do need tools to be well integrated into clinician workflow. That can still happen even if they are out of EHR tools in one sense of that term. But like, yes, I think by and large, and only in rare cases would we, I'd say, approve a tool that's like would take a clinician out of their workflow into a totally different tool, because that is, as you said, it's just it's very difficult from sort of like a fatigue perspective. But again, there are external tools that we can still use that we then design to integrate into the Epic EHR. So just because it exists outside of Epic doesn't mean that it can't be integrated. Okay, so let me keep going here. I want to get to these last few pieces. So IMPAC, again, we got a large donor gift, which we were really excited about to help the division work with UCSF Health on building a continuous AI monitoring platform. This will be, I'd say, a combination of monitoring the trustworthiness dimensions on an ongoing basis, but also we want to think about how do we assess whether the value was delivered that we could take back to health AI steering, right? Because they're usually investing in it because they want to improve charge capture, they want to improve clinician experience. So we also want to be the group that can go back to those stakeholders and say, like, yes, this value was delivered or was delivered just for this subset of clinicians. That doesn't necessarily need like continuous monitoring, right? They don't need, you know, to know how many dollars came in each hour. And so, you know, I think we're thinking that there'll be sort of one set of activities that are really back, you know, some kind of dashboard or something that goes back to stakeholders around value. And then there'll also be this real continuous monitoring piece, such that if a model started to perform in a really unexpected way, we could catch that quickly and intervene and pull it out if we needed to. So again, the overarching goal is to build generalizable monitoring infrastructure for enterprise AI tools. We're going to start with 5 particular tools, and then I hope scale up from there. Again, we need to start with developing the measures for performance and trustworthiness. Some of these happened as part of the validation process. So we have to decide, are those the measures we want to take forward for monitoring? Is there a broader set of measures? Or even potentially narrower set of measures. So a lot of the discussions now are what are the most important measures to monitor, and are those the same as the ones you use to evaluate the tool to begin with? And then, as I said, we'll deploy those measures for 2 different broad audiences. One that's thinking more about AI governance within UCSF, and then there's more the external stakeholders, and that could include patients. And so this is where we're thinking a lot about what do patients want to know about how AI is used in their care, and how should we build tools that help support that degree of transparency. Okay, I'm just gonna say, yeah, the measures, you know, they relate to implementation and use of the tools, they relate to algorithmic performance, and they relate to impact on outcomes. So again, if you're interested in AI monitoring, this is a broad set of measures and methods to use. And I just have no doubt that if you're interested in this topic, we will want to work with you on this. Okay, I'm just gonna move forward. So I'll just say personally, like my scientific interest in this is about sort of clinicians and how using AI tools changes clinician work. I'm really interested in this concept of automation bias. How do we measure it? So how can we tell if clinicians are providing enough oversight when we are really expecting them to be in the loop and assessing an output of a tool before it moves forward as part of patient care? And should we be even testing strategies that might help increase clinician vigilance? So you can think of things like what TSA does, where they intentionally introduce, right, something that looks like a gun in a security scanner to see if it's like caught and sort of jar people back into attention. So if we see indications of automation bias, should we be actually doing things like, inserting intentionally wrong medication, recommendations into a note, or making predictions that we know, are not the right ones or dangerous, to see if clinicians are catching them. Again, not saying we're ready for that, but I think this is some of the science that, to my mind, is really interesting as we think about augmented intelligence, where we want clinicians to be in the loop and have oversight. So that's some of the science that I'm personally excited about. But again, there's just so many scientific questions. I think we're trying to figure out, can you do AI monitoring in some kind of an automated way? Can you use GPT to evaluate the output of GPT and basically train it to catch its own errors? So that's one of the scientific questions that we're thinking about and would love collaboration on. And then to the question that came up, right? Some ethical questions. What do patients want to know about how AI is used in their care? I would love to do a survey of our UCSF health patients to understand some of their preferences and maybe do some user-centered design work to think about how to, how to present back information about our use of AI. So, and then we're doing this in partnership, I'd say, with, again, a lot of other national organizations that are trying to think about this. So it's a really exciting area where there's lots of opportunities. Okay, that was a lot, but I think I managed to get through it in an hour. And the goals were to tell you about the division and then to do a little bit of a deeper dive into what we're doing with our health system around AI monitoring, and where I think there's lots of opportunity for partnership and research that will directly feed into how the health system is working with AI. So I will stop there, and if maybe we have time for another question or two.
Yeah. First of all, thank you.
Yeah, my pleasure.
I have a question that this idea of automation bias really brings to my mind the idea that AI is an intervention in the health system. And just like we have CPT codes for all sorts of drugs and surgical interventions and other types of intervention, do we have an infrastructure for tracking the use of AI so that we can retrospectively evaluate things like automation bias, or how an AI intervention actually affects clinicians' behavior? Does it increase the standardization of the way people take notes, the way people make decisions, or is it something that's left untracked because we don't have formal codes or something to track the use of AI yet? I'm not sure if that's actually the case.
Yeah, no, we do have a way to track notes. It actually goes back to the metadata that I talked about before. So there's a metadata tag that will tell us if that note started out as something that came out of an AI scribe tool, but then we can also see the manual edits. So when did the clinician review the note? What edits did they make to the note? So so at least in that example, we do. There are other examples where you could imagine a more targeted clinical prediction that's just shown on a screen with a lot of other information. And in that case, we may not have the metadata to say well, did the clinicians actually see that piece of data on a screen? That's one of the limits of these metadata. So unless there's an interaction with that piece of information, you had to check I saw this or I didn't. If there's a box like that, then yes, we would know. But if it's just one piece of data among many on a screen, we won't always know. We can know that it was shown, but we can't know whether the clinician actually saw it. So the answer is it varies a bit, but at least for things
there's no international standard like OECD codes and the European codes. It's institution level.
Yeah. So that. Yeah, the only standard that exists is around interaction with PHI. For HIPAA purposes, you have to know who saw which PHI when. That's the only standard that exists, and it's not really built for this AI use case. So it's, there's something there, but it's not really built for this purpose.
Okay, I think we can take questions from the room first, and then we can read the ones online.
Yeah.
Any questions? maybe you can read the virtual ones while
Yeah,
people.
absolutely. Yeah, there's a question of how long we should prospectively test new tools before moving on. Again, it's a great question. I think, partly we don't have like a set, like it has to be done for 2 weeks or 4 weeks. If we really think about the tool, what it's doing, how many people are using it, in order to feel like we get a clear enough understanding of its prospective performance. And so, yeah, I could go back to the team and find out in general, like empirically for the tools we've put through, how long it's been through. I don't know that off the top of my head, but again, I don't think that there's like a clear standard that's used for that piece. And there's a question about how did I get interested in clinician experience? Yeah, I mean, I'm a social scientist by training, and I think I've always really been interested in more the human side of how technology changes work. And so that's sort of always been my research interest and focus. So, yeah, I think that's there's so many interesting questions that range from like the purely computational to sort of social science to policy. And so, that's for me, those were just the research questions that I found more interesting. And then a question about how is AI different or not from already established technologies, which is a great question because in some ways, much of AI is just trying to be clinical decision support, which we've had for decades and decades. I think what's fundamentally different about it is that most clinical decision support is rules-based, right? So we know exactly, like when this is true, this is what the clinician will see. With AI, it's not rules-based, right? And so that means that the models themselves change over time. And so it's why the monitoring piece, monitoring's also always been important, but I'll say monitoring now feels critical in a way that it hasn't before, because the models themselves can change and we need to understand why they're changing and if they're changing in ways that are making them better or not. And there's this complex interaction, right, between like as clinicians learn about the models and what they tell them, the clinician's behavior will probably change. And so then that will then result in different data that then the models are using to retrain. So again, sometimes it depends on the situation, but I think AI is fundamentally different in that sort of interaction between the model itself changing, the data changing, and then the humans who are interacting with the models that will also change over time. So that is quite different than just a sort of more brittle rules-based approach to clinical decision support.
So one other question I had is regarding adoption of a certain tool. I noticed that you have like 2 scribe systems from 2 different vendors. Is this like up to the clinician's preference, or is this like an institution level kind of approach for adoption that you just need to like approve that this is a tool that passed your oversight test, but then clinicians are free to use the tools that they prefer?
Yeah. So the short answer is like we wanted to test at least 2 tools so that we could see which ones were better. And it's early enough in this that we thought both had a chance. I will just say that one of the 2 tools our physicians very, very strongly prefer. So now that we're moving to enterprise scale, that will be the tool that we roll out. But I think these are getting sufficiently commoditized that we feel like if that tool turned out to then start performing badly, we could actually switch these out fairly easily. So partly we just wanted enough experience with tools that we like could understand what's out there, make an initial decision for a preferred tool, but we want to, I think, be able to be nimble. And so no, we're not going to say pick any tool you want. We're going to go with the tool that our physicians liked better. This is all happening right now. And then once, but we will have, I think, like at least a second and third tool kind of in our back pocket so that whether it's in specific areas or if like the main choice, if we saw that something changed, we could really quickly sort of swap out the tool.
And is there any level of customization for these tools to the institution? Because I'm not sure if like AI as a data-driven intervention, pretty much like a human-facing software, there might be different, idiosyncrasies to different institutions of like how, like whether I need to actually fine-tune these tools to the specific institution's data, or do we just always use like third-party, just closed source like tool, and it's really just the approval and the oversight stage that that's how the institution interacts with the tool.
Yeah, I'd say full spectrum, like examples of all of those. Like, we usually do some local validation, but we always do local validation, but whether we also do local customization really varies. And in part depends on how the tool performs out of the box. If it doesn't perform well, then we would need to do that if we want to move forward. But I wouldn't say, like, the goal in general is to customize as little as possible because that's costly and complex. But there are times where we absolutely will need to do that, and have needed to do that. And so, I think the point is we do that where it's needed. We're just not at a point in AI maturity where we're just seeing tools that you can just take off the shelf and plug right in. Even the ones that are the closest to that have still needed, I'd say, some work to validate. And again, hopefully the vendors will improve those tools over time too, as they learn. So it's going to be happening at multiple levels, which is exciting, but also complex, right? To think about, like, how the vendors will be improving the tool at the same time we're also trying to improve the local use of that tool.
Any questions? Yeah.
I guess it's two questions. The first one is more so around. It seems like you work specifically with these tools are being used for the clinicians as the primary users of these tools. I was wondering if that's like if clinicians are your primary users, if you're focusing on, or if you're focusing on because EHRs are used by everyone in the health system, so not just clinicians, nurses, social workers. And I guess if clinicians aren't your only users, do you see the difference between the use case and how people use this to the tools or the needs of other people in the health system?
Yeah, I think I heard the question. So if you actually look at some of the administrative AI tools that we're thinking about, like, those are not clinician users, right? Those are like our medical coders. And so, and we're now looking at the AI scribe tools for nurses. So, I do think, no, it's not just physicians, or not even just physicians and nurses. I think there will be an interest in AI tools to help anyone who's doing their work, again, where AI is the right tool to be helpful. And so again, that's why I really wanted to show you that enterprise roadmap, because, like, the people who are picking up the phone is in our contact center, right? Like, they will be using AI. So we're really trying to figure out what are the pieces of what a health system does that are best enabled by AI, and that will, I think, touch a very broad array of roles and jobs. Did I hear the question correctly?
Yeah. And were you also involved at all with the deployment of Versa, the GPT tool?
Versa.
Were you involved in that, or was you involved in that at all?
Yeah. So the question was, I involved in Versa?
Is Doc IT involved in the deployment of Versa at UCSF, or is this like a separate thing?
So no, Versa is again an enterprise tool, and that was put out by the Tiger team that really sat under our chief data officer, Key Lai, and that sort of enterprise infrastructure and analytics. So we don't build any infrastructure, again, for the health system or for campus, but I'd say we are there maybe like expert users. So we have a lot of people in Doc IT who like use Versa as part of their research and are thinking about some of the clinical integration pieces. So I'd say that's, we're close partners with the team, but we're not actually building or developing any infrastructure ourselves.
Any other questions? Okay, let's thank Julia again. I think that's a great overview of Doc IT and what it does. And like, if you're interested in collaborating with that division, I hope that will be okay to reach out to like you or any of the faculty. We will share the slides with everyone, and they can reach to faculty members of Doc IT. But thank you so much for joining us.
Wonderful.
and
for keeping you beyond the 11 a.m.
No problem. Thanks for inviting me.
Thank you. Thanks,
Okay,
everyone.
Take care.